Agent shot, lateral. We are going to be performing Deuk laser disc repair on a patient who has a herniated disc in their back, in the lumbar spine. They have an L4, L5 disc herniation. It's on the right side, and it's causing right leg pain. So our patient is laying on their belly, and we're starting to gain access. This will be a transforaminal surgery. You got to just relax a little bit, my friend. All right. Shot. So right now you can see L4-5 disc between the L4 and L5 vertebral body. The tip of this needle is right at the facet joint at L4 and L5. Shot. And the way we're navigating is we're using something called X-ray. Shot. And the X-ray shot allows me to see the spine, which is the part of the body we're trying to fix, by the way. You okay? Can you hear me? Yeah. So I need you to speak up when I ask you a question and just say yes or no. Shot. I can feel your herniation right now. How's your leg? All right. Did you have any back pain? Never? You did at the beginning. When did the back pain go away? After the epidurals. So your back pain got better with the epidurals. When was the last time you had back pain? Wow, so a few years ago. So you've been suffering with just the leg pain. All right. The buttock? Okay. So our patient injured his L4-5 disc, and he has a herniation off to the right side as opposed to the left side, and it's pushing on the right, pretty much the L4, L5 nerve roots, okay? And it's causing him to have leg pain. So we're here to fix that. And we're doing it with a new surgical technique called the Deuk laser disc repair. Now, basically the Deuk laser disc repair, the type of surgery is a endoscopic surgery, transforaminal. And this is a technique that only a few spine surgeons in the world know how to do, the endoscopic transforaminal approach. And the Deuk laser disc repair is one version of that. And it has a very unique feature. It's an annular debridement. All right. You comfortable? Do you feel that back pain you had 2 years ago? Okay. No pain? All right. All right. That's L4-5. I feel very comfortable that that's the L4-5 disc. You can see there's a disc below. That's L5S1. Let's just get a... Are you okay? All right. Just lay still. You can go to sleep now. We're going to have you count from 1 to 100. Let me take a look at that disc. I need you to lower the table just half an inch and move the fluoro slightly south. I want to verify that that's L4-5. There is a disc below as far as I can see on the X-ray. Yeah. Can you wag it just a little bit? I want to look down the 5-1 disc. And it's not that I'm doubting the level we're at. I just want to be absolutely sure. So on the MRI scan, I can see there's a disc at L5S1, which is what I'm seeing below where we injected the dye. And I can see the L4-5 disc, and that's where the herniation is. So I feel very confident we're at L4-5 because I can see an L5S1 disc. All right, let's go back to L4-5. You can move north just a little bit, and we can keep the table where it is. So at this point, we've accessed the disc through a transforaminal approach with this needle, and we're going to put a guide wire down, and then I'm going to take this needle out. So far the first thing we did was a discogram. And a discogram is a pretty common procedure. There's a lot of doctors that know how to do discograms, from orthopedic surgeons to interventional pain management to neurosurgeons, like myself. But the next step here, the incision, is not done by interventionalists. It's only done by surgeons. Surgeons make incisions. Of course, nowadays there's a lot of crowding of things where you have doctors who aren't really trained to do surgery that are trying to do surgery. So you just have to be careful who you work with. But basically we're introducing a surgical instrument called a dilator. And the dilator is going to go down to the spine. And it's going to go through the foramen. Just lay still, you're doing great. So we've made a 7 millimeter incision on the right side, the right flank. The line here represents the middle of the spine, the middle of the back. We've only draped open the right side of his flank. The left side is closed. And you can kind of see where my hands are, the two sides, the two flanks. So that's in the middle, and we're way off to the right side because he has right leg pain. The herniation's off to the right side. We want to go on the right side. All right. Let me know if I can proceed. Huh? Yep. So what I'm about to do is I'm about to advance the tip of this dilator, which looks like a metal pencil, into the herniation. Right now it's sitting at the tip of the herniation. And when I do that, a couple of things are going to happen. I'm going to enter the disc space through the annular tear, which is exactly the most perfect thing you can do in this case. But I'm also going to push some of that herniation into the disc, which makes it safer and easier for me to remove the herniation, because I've just now moved it from where the nerve is in the foramen into the disc itself. Huh? All right, so I'm going to use an impactor to do that. Shot. Unfortunately, this is the more painful part of the surgery. Patients don't like it because this is where all the pain fibers are that are causing their pain. Shot. Mallet. Yeah, I'm not done advancing it. Shot. That looks good. So I'm in as far as I want to be. Now I'm going to show you folks. We're doing the entire surgery today on the L45 disc through a metal tube this big. It's 7 millimeter diameter. This is the year 2020. It's September 10th. September 10th, 2020. There are probably only 20 surgeons in the world that can do this transforaminal surgery and put this dilator into the disc, okay? Have there been more trained? Yes, but they don't do it because they're not confident that they can do it safely. So this is a surgical technique that there haven't been very many people trained, and of those people that have been trained, less than 1% of spine surgeons, that less than 1% that have been trained, only less than 1% of those people actually do the surgery, because it is technically somewhat difficult to do, but it also requires equipment that most hospitals don't have. Shot. You're okay. Can we get him a little better control? Shot. All right. We're in. You're doing great. Everything's okay. All right. Let's get the fluoro out. So you can see the tubular dilator is inside the disc space. And I'll just tell you, I've said this before, there's two ways to do this. One is the outside-in technique, and the other is the inside-out technique. I learned the inside-out technique from the pioneer, Dr. Anthony Young, Tony Young, out of Phoenix, Arizona. And I also learned the outside-in technique from Dr. Knight, Martin Knight, in Great Britain. And I don't do the outside-in technique because it's not as safe. I do the inside-out technique. And I would recommend anyone doing this type of surgery to do the inside-out technique. That was pioneered by Dr. Anthony Young. Okay? Alrighty, the blue dye is a dye that we put in ourselves. See that right there? That's a piece of the herniation. You see that yellow thing? So I pushed that herniation back into the disc, and now we're going to retrieve it. Now herniations, unfortunately, they don't come out as one piece. Can we get him a little more comfortable? Everything's okay, you're fine. Herniations, okay, you gotta tell him how to manage that. He's about to drop the herniation. Look at that right there, okay?
So just drop that one over here. Grab a new one because this is a specimen that we're gonna send for pathology, right?
Yeah, we have a lot of disc for some reason. Normally we don't get this much. What's going on over there? Huh? Eating it up? The propofol? We have a patient coming, by the way, probably coming soon. She's going to be an ACDF. She has a history of malignant hyperthermia. I've never operated on a patient with malignant hyperthermia. That'll be a first. But obviously, we want like virtually zero risk, you know what I mean? Would propofol be the way to go? We're going to what? Yeah. All right, so what? She would be the first case of the day? All right. Yeah, it's an hour-long case, and is he okay? Just a little bucking. He's fine? All right, so we're doing one disc, and you can see the tear right there in the annulus. We're going to go in and debride that. The Deuk laser disc repair you're watching is done here exclusively at Deuk Spine Institute in Florida in the year 2020. In the future, it'll probably be done elsewhere. But right now it's done here, and what's unique about the surgery is what I'm doing right now with the laser. We're one of the few in the world that actually really use the laser to do the surgery. Even Laser Spine Institute, when they were in business, and they went out of business a year ago, even they did not use the laser. How do I know that? Because I have surgeon friends who work there. They use the laser as a marketing gimmick. They didn't actually use the laser during surgery. They just did a typical microdiscectomy, basically. All right, so this is a very scarred up herniation. Do we know when his date of injury was? I'm pretty sure it was a while ago, right? You okay? Yep. All right, yeah, this is... How many? 2 years ago?
Gary, the suction on the bag is on? The suction on the bag is on, right? Perfect.
Yeah, that suction should not be on ever. Okay, right there.
Yes, sir. I don't feel it.
You
Gary,
get that, Cam?
the suction from the bag.
Did
I
you
don't
hear me,
feel it.
Cam? This suction should not be on. Yeah. You're fine. Everything's okay. Just lay still. You're doing great. Standby laser.
Perfect.
You're okay. We're going to send those pieces of disc material to the pathologist. Let them look at it. Take that. You're doing great. You got to make sure you hand me the right side, okay? And you'll get this, Cam. There's a lot going on. It always seems a lot easier than it really is, but once you've done enough of them, you start looking around and seeing other things happening, and you get to participate. It's kind of like going to Universal Studios for the first time. When you get there, you're just amazed at all the roller coasters and all the activities, the games and the stores and the food, and you're kind of overwhelmed. But then once you've gone there like 10 times, you walk in that gate and you go straight to the Hulk roller coaster, and right after the Hulk you go straight to Spider-Man, and right after Spider-Man you go straight to Dueling Dragons, which is no longer, I think it's still there. And then you go to the Harry Potter ride. And then you go to the water park. Point is, you develop a system, right? A protocol that works for you. And don't forget the Jurassic Park ride, right? You grab a turkey leg from one of the vendors in Jurassic Park once you get off the ride and your stomach is settled down. Have you been to Universal?
I actually went a couple weeks ago.
Oh yeah? Good. Which one? Islands of Adventure or?
I believe it's
Huh?
Studios.
Universal Studios?
Yeah.
What ride did you go on?
We went on Hulk. That was the last one.
All right, you went to Islands of Adventure. Yeah, Hulk is only at Islands of Adventure. That was the last ride you went on?
Yeah.
So you must have turned right when you came in. So it's a loop that goes around all the rides. You either go right or you go left. We always go left. We start with the Hulk. I love that ride. That's such a good ride. Isn't that incredible how it just launches you out of the tunnel?
Oh, yeah.
Totally unexpected. You didn't know it, did you? Or maybe you watched some people?
That was my first time there. I've been to the one in California.
Well, you're from Tampa, right?
I'm from California.
Yeah, but, okay, so you're originally Cali. Where are you from in Cali?
Mostly Orange County, and I went to high school in San Jose.
San Jose and Orange County. All right. Well, obviously, I'm from Thousand Oaks, Ventura County, a little north of you.
I had an off season in Fort Hueneme.
Sure.
Trained there 1 year.
That's a popular place to surf.
Yeah, I didn't surf back then.
Oh, yeah? By the way, if you're watching surgery today on our channel, either YouTube, Periscope, Facebook, we are streaming live spine surgery around the world. We've been doing that 6 years now. And can I get you to move that IV pole just towards you about a foot? Perfect. That's enough. That's enough. I just need to see the screen. We've been streaming from Deuk Spine Institute live surgery for 6 years. We do it every week that we operate. We do it every single surgery we operate. We have not streamed a surgery in 6 years. So why do we do this? Because I'll be perfectly honest with you. I have no faith in our educational system anymore in the United States. I've watched it just deteriorate over the years. And it's not getting better, it's getting worse. The techniques that are being taught in residency to do surgery, the knowledge is insufficient to make good surgeons. And I'm very critical of our system. So what I've decided the most effective way I could teach future surgeons to do these surgeries is by videoing them in high definition with a combination of third-person view, which is their camera up in the ceiling, combined with first-person view, which is through my eyes, using a GoPro on my headlight, and also integrating everything that I use as the surgeon to make decisions. So that would include the X-ray, the microscope if we need it, the endoscope. Right now you're looking at the endoscopic view. You're looking at basically through a camera pointed inside the disc, using a long tube that has illumination and lenses that transmit the image at the end of the tube right to the screen that you're watching. And just to give you a perspective on how big everything is in here, that silvery thing that you see all the way around, that's that 7 millimeter tube. But the internal diameter is about 6 millimeters, okay? Maybe 5.8 millimeters, just under. So the walls of it are about 0.6 millimeters, 0.7 millimeters on each wall. So your internal diameter of this tube is, you know, it's just under 6 millimeters. It's around 5.8. Is everything okay? All right. That being said, the blue casing around the laser fiber, which is glass, it's a little glass thing, that is 0.5 millimeters. It's half a millimeter. Okay, so you have a very magnified view of the inside of the disc, and we are literally inside the disc. The tip of that laser is touching herniation inside the disc. And I've been zapping away at it, and it's really taking a long time to get rid of this stuff because it's so scarred in. It's so scarred in. His injury was several years ago, is my understanding. And after a couple of years of inflammation in the disc, you're going to get a lot of scar tissue. Oh, he's happily snoring. He's probably having wonderful dreams. I'm talking about our patient, of course, not the anesthesiologist. Our patients receive, during the laser surgery, propofol sedation through their veins. It's a liquid medicine that is rapidly distributed throughout the body. It is considered the very best anesthetic agent for IV anesthesia, at least in my opinion, for these types of applications. Most anesthesiologists would agree, and the reason is that the recovery is so quick and the patient's not drowsy. They don't get a lot of the side effects of other medications that have been used in the past. This is a newer medication. We started using this in my residency in neurosurgery back at Shands Hospital. That was back in 97. We were using it, and we use it pretty much every single day to care for patients in the ICU that needed sedation. And of course it's used here in surgery centers. All right, we're going to pull back on the tube. The more we pull back, the more we're heading towards, this is all herniation, by the way, the more we're heading towards the nerve root, where the nerve is. That's a piece of herniation just squeezed out of there. Looked pretty weird, huh? Normally the disc is white. Now the blue stain is something that I put in during the discogram. And what it does is it binds to, the blue stain binds to degenerated nucleus pulposus. Nucleus pulposus is the middle of the disc. It's really the jelly core. You can see some fresher nucleus right there. Again, still degenerating, not normal. Normal disc won't stain. Normal disc is white. The nucleus is normally white, and it will not stain with the blue. It'll stay white, even if you put the blue dye on it, because it has to be degenerating. It has to be damaged, and it has to be basically under the influence of the inflammatory system, an inflammatory cascade. That inflammation degenerates the disc. It's inflammation that does that. Chronic inflammation. You have to pinch it. Piece of herniation there I'm trying to get out. All right. Without the effects of inflammation, the nuclear material won't degenerate. So a lot of people say, but Dr. Deuk, there's no blood supply to the disc. How could inflammation possibly be happening without blood supply? Well, that is an oversimplification if you were to say there's no blood supply to the disc, because there is blood supply to the disc. And the center of the disc normally has no blood supply, the nucleus pulposus. Everything it gets from your circulatory system is via a process called diffusion, where substances move down their concentration gradients. So the capillaries in the outer half of the annulus fibrosus release substances like glucose, oxygen, into the outer part of the disc, and then they diffuse to the inner part of the disc. And when they get to the inner part of the disc, they're consumed and used by the nuclear material. The nucleus pulposus is very metabolically inactive. It doesn't require a lot of sugar or oxygen. It doesn't produce much carbon dioxide as a metabolic byproduct. So the nucleus pulposus is metabolically inactive. The most metabolically active tissue in the human body is the brain. The most metabolically inactive tissue in the human body is pretty much the nucleus pulposus or the lens of the eye. Basically, tissues without a blood supply. There aren't many of them. There's only like 2 or 3 tissues in the human body that don't have a blood supply. The lens is one. The eye basically has 2 of them, and the spinal disc is another. Every other tissue has a blood supply. And the blood supply to tissue is proportional to the amount of metabolic activity that tissue has. Metabolic activity means that the tissue is very busy synthesizing proteins and carbohydrates that are used for its functionality, or creating a electrochemical gradient across the cell membrane. Electrochemical gradients are they're like the water behind a dam, a hydroelectric dam. It's what drives the energy of a cell. Neurons have very, very important electrochemical gradients. The electrochemical gradient, for those of you who don't know, is basically a gradient of charged ions, where you have a gradient of positive to negative across the cell membrane, which is hydrophobic and allows separation of charge, much like a capacitor in physics. But there's also a chemical gradient, which means it's a concentration gradient difference from one side to the other. So you have greater charge of positive on one side relative to negative charge on the other, but you also have greater numbers on one side compared to the other. So you have 2 driving forces. You have the charge differential across the membrane, and you have the gradient, the concentration gradient differential. And both of them drive the movement of substances. So we use energy in our cells to create that electrochemical gradient, and it's a storage form of energy. How do I know all this? I know this because I'm a biochemist. And I spent many, many years studying biochemistry, cell biology, chemistry. That's what happens when you actually go to school and study hard. You get smart, and you start to understand everything. Unfortunately, the way I see education happening nowadays is that people just want to sit at home and get on the computer for an hour, and they think they can learn everything that we learned in my generation by doing that. The truth is that before there were computers and online classes, the smart people used to go to class and sit in class for 10 hours a day, literally all day getting lectured to, with information constantly being streamed. And we would take notes, we would go home and we'd review those notes until midnight, and we'd be back at it at 7 a.m. the next day. And we did this literally 5 days a week, and then on the weekends we would study 12 hours a day on Saturday and 12 hours a day on Sunday. At least 12 hours, sometimes more, 18 hours, 20 hours, if there was a test. The point I'm trying to make is that I don't think the future generations of doctors, scientists in this country are going to be better than the older generations, because the educational process is flawed, and I only see it getting worse, especially with coronavirus. More and more homeschooling, And that's, to me, is just not real schooling. So I believe someday, 10, 20 years from now, the transfer of knowledge from one human to another through all the traditional routes is going to be gone. And it's all going to be done through computers. And it's going to be subpar, massively inadequate for the future doctors and scientists and people to really understand disease and how to cure it. So I'm going to memorialize everything I know on videos. Okay? And I'm doing that by broadcasting live surgery around the world. The rest of you have the benefit of watching it and learning, but I'm creating basically a library of knowledge and experience and successful application of technique in medicine to cure things like back pain.
We have a question.
If you've ever watched a shooting comet at night, you stand out under the night sky waiting, and then suddenly you see a star fall out of the sky and streak, and then it's gone. And if it's Halley's Comet, it's gone for what, 20 years? Right? You won't see it again. So if you want to see it again, you have to video it and you have to capture it. Otherwise, you won't see it again. And for people who have never seen a comet across the night sky, they'll never really understand what it is, the significance of it. So what I'm doing is I'm trying to use my time wisely here on Earth to create a video library of successful surgical techniques of the spine. I'm not the first person to think of doing it. I heard that you have a question. I'll get to it in a minute. I want to finish my point. As a matter of fact, the first neurosurgical memorialization of technique was a series of books called the Neurosurgical Operative Atlas. The Neurosurgical Operative Atlas. And when I was a resident at Chance Hospital, when I started my residency, the chairman would give every new resident a budget of $1,000, and you could buy with that $1,000 whatever book you wanted to buy or books you wanted to buy. I bought a series of books that no one else had ever bought, but it had been available, and it was called the Neurosurgical Operative Atlas. And it was like 8 volumes of books with colored pictures of how to do spine surgery or brain surgery, aneurysms, AVMs, everything neurosurgical. All the other residents would buy the board review books and little paperback stuff that was cheap, and they would get 5 or 6 books. But I blew my load on one series called the Neurosurgical Operative Atlas, and that made such an impression to me because before the surgeries, this is really before the internet was popular for having so much information, especially related to science and medicine. You could never really go on the internet back then in 97, and you couldn't find how to do surgeries, you know what I mean? And unfortunately, in neurosurgery residency, there's not a lot of teaching that goes on directly. You have to learn by watching the surgery yourself. But if you have no clue what's going on in the surgery and nobody takes the time to explain it to you, how are you going to learn? And so it's a flawed system of education, even when I was in it. So I bought the Neurosurgical Operative Atlas because it had pictures and diagrams and showed the anatomy, the operative approach, the surgical window. And I started to be able to read about the surgeries I was doing the next day. I would read about them the night before, you know, and I would learn what was going to happen. And so being able to see that surgery done in a book before I actually did it was hugely beneficial to allowing me to get more out of that surgical experience. So what I'm getting at is I'm creating that Neurosurgical Operative Atlas right here, right now, for future generations. And I'm the only one in the world doing it. Yes, there are people who have surgeries that are broadcasted, but they're always edited, and they only do 1 or 2. We do every single surgery as broadcast. Look at that little vein right there. It's almost a capillary. All right, what's the question?
We just have a viewer wondering if you can clarify what they're looking at. They're wondering what the white stuff, yellow stuff, and blue stuff is on the screen.
White, yellow, and blue. All right. One of our viewers is saying, hey, Doc, what do you got going on in there? Okay. So on the left is the end plate of L5. On the right is the end plate of L4. And this is the disc right here, and that's the annulus. And it was torn and full of herniated material, and I just zapped it all away with the laser. So the blue stuff is the nucleus pulposus. The white stuff is annulus fibrosus and scar tissue. Up here, the yellowish stuff is fat in the epidural space. If I come back a little more, you'll see more of it. The nerve root is right up here. See the white thing there? It's now at 12 o'clock, that white. That's dura. That's the covering of the nerve root. This stuff right here is herniated disc. This is part that I haven't gotten rid of yet. It's right up against the end plate, and it's close to the nerve root. So you want to just be real careful when you do this. I hope that that helps. The yellow stuff is basically calcified disc. The yellow is always calcium. There goes a piece of herniation. You see that shoot off? All right. So I think he's going to be happy with the amount of relief he gets in his leg. We're actually in the neuroforamen right now. This is the outside-in approach. Like, this is the outside in. If I started the surgery right here and I went into the disc herniation, then that would be outside in. But I actually did inside out. But this is what Dr. Knight does. He comes in the foramen and then works his way down to the disc. I do the opposite. I start in the disc and work my way out to the foramen. Okay, very important thing to remember. This is all lateral herniation, just making sure this doesn't cause problems for our patient after surgery. That stuff is fat right there. You see it? That's what fat looks like. You can almost see, you can actually see every single cell of the fat. I'll show you. Give me a second. All right, look at that. Okay, that's fat. See it glistening? Each one of those, like, reflections, like a diamond reflection, each one of those is a fat cell. And that's blood. You can almost see the individual red blood cells. That's how good the view is. Pretty neat, huh? Neato bandito. Only at Deuk Spine, folks. All right. There's the nerve root again. Looks good. That's where the herniation was. Looks good. All right. We're done. So we're going to come out, suck the water out, scope off. Now go ahead and take a look. Take this. We need Dr. Patel, if we haven't already called him. Let's let him know we need him right away. All right, so for those of you wondering what were we doing, Sean, you see all this?
Yes, we can.
Yeah. So this is what I use. This is called the rig. Endoscopic spine surgeons, we call this the rig. Or endoscopic surgeons, I apologize. All endoscopic surgeons pretty much call this the rig, the rig. Don't ask me why I didn't make it up, but it is a rig. So you've got your endoscope, you got your camera, right? Can you all see that? Are you all? So the camera transmits the image seen right here. You have your light source, which is the blue. You have your irrigation source right here, which we'll take off. Go ahead and clamp that. You can see a little water fountain here. All right. All right, then you got your scope. Believe it or not, this is everyone says, why is this surgery so expensive? Because the equipment is expensive. Millions of dollars worth of equipment. Just this thing alone is 12 grand. 12,000 US dollars. All right, here you go. Can't just have one either. Now I'm going to take this out. Okay, and show you, let's put some pressure here. We're going to put pressure on the paraspinous muscle that we just went through. And the reason for that is sometimes there's a little bit of bleeding in the muscle. We don't want a blood clot to form inside the muscle. All right, here's the fluid adapter. No big deal. Take this, Luis. Suction line. But here's what we did the whole surgery through. This little tube. You see that? You were looking out the end right there. Now let's show the incision. The incision is right there. You all see that? Half of the width of a dime. The whole surgery done through that. And no bone has been removed from this patient's spine. That's very important. No bone removed. Every other spine surgeon you go to will take the bone and drill it away and remove it. And you're going to be left with a hole in your spine, right where you had your discectomy done. And that hole, over time, is going to weaken your spine, and your spine is going to start wobbling around, and you're going to need a fusion later on. So none of our patients need fusions. All right, you have any questions?
None others.
I'll head over to the conference room. If you have questions, go ahead and answer them. Ask them, and I'll come and answer them.
All right, everyone, thank you for joining us for the post-op Q&A. We just finished up our first surgery of the day. We have 2 more to go. Both of them are DLDRs like the one you just watched. We are in the post-op Q&A right now, so if you have any remaining questions about this procedure or your own neck and back pain, please post them in the chat. Right now I'm going to hand the microphone over to Dr. Deuk so he can go over the recent success with this case.
All right, folks, I'm here in the conference room with Sean at Control here, Mission Control, where we broadcast live from Deuk Spine Institute here in Melbourne, Florida, located near Orlando. And what this area, by the way, for those of you who aren't familiar with where we are, we're located in a place called the Space Coast. All the rocket launches, including the shuttle launches and the rocket launches that happened, you know, for the trips to the moon, they all occurred at a place called Kennedy Space Center. Kennedy Space Center is located in Cape Canaveral, Florida, and that's where we are. We're in the Space Coast of the United States. We're located literally 10 minutes from the launch pads of NASA, and where the new shuttle program is been developed by Elon Musk and other competitors, commercialized now after the space program was effectively closed, I think by Obama, basically. President Obama closed it down. His first term, I can't say I disagree. The shuttle program went longer than the anticipated, I think 30 years. I think it went to 32 years. And the reason, obviously, it went over its life expectancy was the International Space Station was manned, is manned, and womaned, and they needed supplies. They needed to change out the astronauts that were up there, so we kept launching our shuttles, and the shuttles worked just fine. However, obviously the space program was closed down, and I can tell you why it was closed down. It was closed down, in my opinion, because there was so much governmental corruption and graft between the government and lobbyists and the suppliers that we were way overpaying for each launch. It would cost the taxpayers of the United States probably a multiple of 5 times more than it should have cost. And so Obama saw that as wasted money, which I agree, and he shut it down. But the reality is now we're in a commercial program where we have Elon Musk, and Bezos is going to be competing soon because he's built a 1 million square foot facility right here in the Space Coast called Blue Origin, and they're building rocket engines to go into outer space. So we've commercialized space travel since I've been here, and Deuk Spine Institute was started here in 2004, and we've watched the transition over the last 10 years from basically a federal space program to a commercial space program. But I don't think we're going to get away from paying those high prices that we've paid before. I think it's going to end up being back there. Anytime you commercialize a government subsidized or funded activity, it always ends up being expensive as well. So it'll be interesting to see how they're going to control costs. That being said, back to our surgery. Just for those of you around the world who don't know where Deuk Spine Institute's located, now you can put a little pin on your map. We're located in Florida on the East Coast, right where Cape Canaveral is. If you put your pin on your map, you'll probably be pushing it right through our location. So what kind of surgeries are happening here at Deuk Spine, and why is Deuk Spine Institute special? Deuk Spine Institute is special for a couple of reasons. Number one, we have the ability to diagnose the cause of back pain better than any doctor, any hospital, any facility in the world. And the reason for that is to diagnose the cause of back pain or neck pain. When I say back pain, I'm also referring to neck pain. Really, we're talking about spine-related pain. The reason we have that ability better than anyone else is it requires not just equipment, but it requires expertise through the knowledge and experience of experts. Experts, obviously, in 2020, I'm referring to human beings, not artificial intelligence experts, which I'm sure in the future will have robots that have equal or greater experience than humans at things. But right now, I'm referring to human expertise and knowledge and experience to be able to diagnose the cause of back pain. So back pain has many potential causes. And when I mean by many, I mean over 30 different joints, muscles, tendons that can cause back pain and bones. And so being able to determine what is the cause of each person's back pain takes testing with specialized equipment. It takes sometimes blocking pain sources where we think the pain's coming from. And to do that, you need the right people. You also need the right equipment, and you need the right medications, and you need the right supplies. So equipment, supplies, medication, personnel, that's the winning combination that allows us to do it. Could we teach the diagnosis of back pain to other facilities? Yes, we can. But unfortunately, to teach somebody that you have greater capability than they do, they first have to accept that you have greater capability than they do. And that's not something you'll commonly see, is people accepting that. And that's why people go to war. They go to war because one country thinks it has greater capability than another, and then obviously at the end somebody has greater capability and they win. That's the way it is in everything in life. Same thing in boxing, same thing in sports, soccer. You know, teams compete, people compete because they think they have what it takes to win. Well, the truth is that I've studied and watched every other facility and doctor around the world. I've gone to meetings, I listen to people, I see what they're doing. And Deuk Spine Institute, I can tell you what we do is very unique. We didn't create everything ourselves, we brought it in. We brought in the equipment from outside sources, a lot of it from Germany, some of it from Korea. The point is that we took the best from around the world and we brought it to one location, Deuk Spine. So can you get this? Can you get this quality anywhere in the world? No, you can't. You really can't. And if you want to get fixed, you want your back pain gone, cured, you have to go to a facility that can cure it. And there are very few facilities in the world that can cure back pain. If I had to guess around the world, I'd say there's 10, maybe 5 to 10 that can cure back pain. I don't even know the names of those facilities, but I look at my colleagues, I look at their resources, I look at their support, I look at who they collaborate with when they treat patients, and I can tell you the winning combination comes together less than 10 times in the world. So if you want your back pain cured, you have to go to a facility that can cure it. We had a question from one of our audience, is who would you recommend in Australia? Australia has very good doctors. They have great medicine, trust me, they do. But they don't have what Deuk Spine Institute has. And we have people who travel from Australia who understand that, and they come to Deuk Spine to get fixed, and we fix them. It's going to be that way for a long time. Why? Because it's not just a financial issue of putting a Deuk Spine Institute in Australia so we can treat Australians. It really is an issue of training physicians. So it's not just any physician that can do the surgery. You need a spine surgeon. And the spine surgeons come in two flavors right now, orthopedic surgeons and neurosurgeons. And there are not many orthopedic or neurosurgeons that care about pain, that want to treat pain. They want to make that their life ambition, their goal. There are not many of them that want to be pain doctors. If they wanted to be pain doctors, they would have done anesthesia. They would have done interventional pain management. Unfortunately, that's the way it is. Those are the pathways to treating pain. You become a physiatrist or a neurologist or an anesthesiologist, and you learn how to do shots. Well, none of those doctors, neither a physiatrist, anesthesia, or a neurologist, can do surgery. And the truth is that curing back pain many times requires surgery on the discs to treat the inflammation in the disc, or to stabilize the spine, or to correct alignment, or to decompress the nerves. So those are the things we do as spine surgeons to treat pain. Unfortunately, the doctors that go into pain for their profession are not surgeons for the most part. They're just non-surgeons, which is physiatry, anesthesia, and neurology. So there has to be a complete shift, a change around the world in the way that doctors that treat pain are trained in their training programs, in their residencies. And I want to change that, and I want to create a spine residency. It would be the first in the world. There is no country with a spine residency. How do I know that? Because most countries model their residency programs after Western medicine, including the United States or Britain. And in Western medicine, there's neurosurgery and there's orthopedic surgery, but there's no spine surgery specialty or no spine surgery residency. There needs to be. And if anybody out there is interested in developing one, I'm happy to help you do that. I can't do it all on my own. It's very, very big undertaking. It requires a lot of people collaborating and working together, far greater than the ability that I have in 2020. But long story short, if we want to see other countries have the ability to cure back pain like Deuk Spine Institute does, there has to be a complete makeover of the entire educational system in medicine and training of doctors to treat and cure back pain and neck pain. And I don't see that happening for a long time. And because those kind of changes take big money, and I'm talking big money, $100 million, $200 million, $500 million. It would take somebody like Jeff Bezos or Mark Zuckerberg, one of the big shots that want to make a real change in the world. They could make this change happen. But unfortunately, most of them have their heads stuck so far up their ass, they don't even understand that this is going on, that we've actually revolutionized medicine here at Deuk Spine Institute. Most doctors don't understand it. And so the only way we're going to make change is through our squeaky little radio right here out of Deuk Spine Institute, Sean and I, broadcasting over the internet. Okay? That's it. That's it for today. That's all we can do. We can keep curing patients' pain. We can keep capturing those experiences and sharing them with the rest of the world through what we have available to us. We're not a rich organization. We don't have a lot of money and power and resources in the spine world because other surgeons don't know about this technology. You can imagine they don't embrace it. Other spine surgeons use screws and rods and cages and metal plates, and that's how they, that's how the newest generation of spine surgeons are fixing or trying to fix people, is with fusions and hardware. The truth is all of that is unnecessary in degenerative spine conditions. It's virtually all unnecessary. I've always said about 98% of it is unnecessary. We can cure most people's spine problem without metal, without plastic, without anything being inserted into the spine. Unfortunately, 98% of spine surgery designed to treat degenerative conditions is done with metal and implants today. And so we need a complete shift away from traditional ways of treating spine disorders to the new endoscopic, minimally invasive way, but not just endoscopic surgery. It has to be geared towards the pain generator. And this is taught to me by Dr. Anthony Young. He taught me about the pain generator. He was an orthopedic surgeon. He's retired now, but he's out of Phoenix, Arizona, and he was trained by the pioneers in endoscopic surgery, such as Parvis Camben out of Pittsburgh. So what I'm getting at, folks, in a long-winded explanation, is that don't expect to see this technology near your home anytime soon. It's not because we're hoarding it. It's not because we don't want people to know about it. It's simply because it would be like Moses parting the Red Seas. It's a biblical epic proportion to make these kind of changes happen. And I certainly cannot do it on my own. So it needs support of the public. It needs support of people with money and resources to help do it. And what I envision would be a Deuk Spine Institute in every state of the United States, maybe one in every country, in every major city eventually, as the center where people can go to cure their back pain and neck pain, which is something that no one else really can do right now around the world. And just think about a world without back pain or neck pain. It's possible. We could do it today. All we need is the facilities, and I need to train the people how to diagnose back pain and neck pain properly, which is not that hard to do. But you need doctors that are willing to cooperate and open-minded and willing to learn. And if you have those people and those resources, the ingredients, we could end and cure back pain and neck pain next week. Could be done. All right, I hope you enjoyed the surgery. We're getting ready to do our second surgery of the day. It will be a Deuk laser disc repair, 3-level, L233445. This patient has 3 herniated discs. They're on his left side. He's a Marine, and has constant pain and wants it cured. We offered, to cure it with the Deuk laser disc repair, which you're about to watch. He also had options to do fusion surgery. He didn't want that, or artificial discs. He didn't want that either, because those are far more invasive and dangerous surgeries to do. So we're going to fix it hopefully with 1 incision, maybe 2, just like the surgery you just saw. Hopefully be able to fix all 3 discs with 1 incision. So come back in about 20 minutes.